Hello there, this is Brian Barker, Doctor of Physical Therapy. And today we're going to talk about the subjective history and why it is the most important test. Just a little bit of background. If you truly don't believe this is the most important test in a physical therapy exam, I'm sorry, you're mistaken. So this is just to bring you guys up to speed on what should be included in a subjective exam. Objectives of this presentation is to provide physical therapists with guidelines for subjective history taking, know the reason why the subjective question is important, how to effectively build patient rapport, and show the value of effective communication on therapeutic outcome. So the first thing that you're going to do, okay, is you're going to introduce yourself. So you go up to the patient, explain, hi, my name is, Susie. I'm a doctor of physical therapy student. Nice to meet you today. Giving them a nice handshake, unless, well, they're in a sling, probably not going to give them a handshake, or maybe shake their other hand, okay? When you meet that patient for the first time, making eye contact, trying to make them feel as comfortable as possible, but also not only greeting them, but greeting everyone in their party. Make it feel like everybody is acknowledged, regardless how little or they are. So even children acknowledge, hi, nice to meet you. I do this simply by saying, hi, my name is Dr. Brian Barker, and I'm going to be the one taking care of you today, but you can call me Brian. I try to keep it light. It's my own personal thing, but you make sure you greet everyone in the party. Apologize if you're running a few minutes late. At times, whether it be the computer system is acting up a little bit, they maybe took a little bit more time for their paperwork, or you're finishing up with a patient before them just a tiny bit late. If you are running late, acknowledge it, apologize, make them feel like their time is valued, and that you're ready to go for them. Next year, look good, smell good, okay? People are coming in and they want to feel at home. They want to know who the physical therapist is. You want to be able to, in any situation in a physical therapy clinic, not be second guessing who is the patient and who is the physical therapist. So whether that means a nice pair of slacks, polo shirt, button-up shirt, for women a nice blouse, a nice pair of shoes, make sure that there is no doubt that you are the physical therapist in the situation. All right, smell good, because let's face it, physical therapy is a contact sport. More than likely, you're going to be pretty close into somebody's business, so make sure you're wearing deodorant, a stick of gum before you start talking. It does matter, okay? Treat them like a close friend. I say close friend because when you meet them, you want to make them feel relaxed at home. You have to always remember they're coming to a doctor's office, a healthcare office, and at times previous healthcare providers maybe don't feel like they give them the time, or they feel rushed, or they can't ask all those questions that they want to, or maybe they were, in the waiting room for an hour and a half waiting for their appointment. We want to be the good guys of healthcare. We want to show them how much we actually care about them. Next year, explain the process. When I say this, I mean frame the visit, okay? As you're bringing them back to the treatment table, saying, hi, nice to meet you, Susie. Today we're going to figure out your story, figure out what's going on with you. We're going to do some tests to see how well you're moving today. And then at the end, we're going to explain what we found and then get to a little bit of treatment today. That way you're able to frame the visit to know what the patient is going to expect. All right, the first question, open-ended, saying their first name. The reason I have this down here is because that patient wants to know you care about them. Going back to treat them like your friend. Hey, Susie, you know what? How can I help you today? Or hey, Susie, tell me your story. Or hey, Susie, what brings you in today? Open-ended questions. Most of the time, the patient is going to give you all the information that you need. Let them. Okay, and the next step is pretty self-explanatory, but possibly the hardest thing to do is just sit down and listen. All right, let's talk about the things that we need to get from our subjective history, okay? When did things start or slash duration, okay? Are they getting better? Are they staying the same? Are they getting worse? Something to really hit home on is you really want to know when this started. Some patients will come in and say, I've had back pain for 10 years. Okay, well, in those 10 years, has it gotten better? Has it gotten worse? Has it stayed the same? Have you had flare ups? We need to understand the symptom behavior to properly gauge our next part of our exam. Okay, aggravating factors. How long and more specifically with aggravating factors, how long does it take for things to come on? Because sometimes if somebody says, well, standing makes it worse. Well, how long do they have to stand? Is it from the second that they get up out of the chair? Or is it, well, I've got to stand for 4 hours while I'm at work? It's going to completely change the next part of your objective exam, okay? Because if it's immediately, you're going to tread pretty light. Like, okay, well, I'm going to be able to turn this person's symptoms on really quickly, okay? Easing factors, and also just like worsening factors, how long to ease. This is important because if the irritability of the patient's injury is very, very high, and for Susie, the second she stands up, she has 8 out of 10 back pain, and the rest of the day, she has 8 out of 10 back pain until she goes to sleep and wakes up the next day. Well, that's going to completely change my objective exam. 24-hour pain pattern. Is it better in the morning? Is it better in the middle parts of the day? Is it better at night? Okay, it's going to give you a good idea of just how symptoms are changing throughout the day, and not to mention, especially if things don't really change that much throughout the day or intensify at night, our differential diagnosis questions might need to come into here more. All right, was imaging performed? This is just good to ask because it helps give us a little bit more information, whether it be X-ray, MRI, bone scans, whatever testing was done, it just gives us another piece of the puzzle. Other treatments attempted. So when I mention this, whether it be chiropractic treatment, injections, icing, medication, going to the German Mennonite farmer, things are needed to know what has been done, what worked, what hasn't worked, and where they're going. Medical history. So medical history is important because previous injuries usually impact current ones. If somebody's knee is hurting because they had a sprained ankle that they can't put together 3 years ago has progressively made their knee hurt, that's our job to put those pieces together for them. So having a thorough medical history and orthopedic history will also be helpful and needed. Their occupation, so whether they primarily work a desk job, whether they work at a feedlot, whether they're a professional athlete, whether they're a student, all of these things will give us a little bit more information because we know what they're doing throughout their day, okay? So the other thing you need to make sure is you can't assume. If somebody says, I work at the bank, you can't assume that it's going to be a desk job all day. Maybe they're a teller and stand most of the day. Maybe they're hauling money from one end of the bank to the other. We need to get the very detailed, what do you actually do throughout your day? Because that's going to probably determine the type of objective exam we will do. What are you hoping to get out of therapy? Okay, I love this question because if you ask a patient, what are your goals of therapy? That just sounds way too scripted. It's not very personal. What are you hoping to get out of therapy, Susie? We're getting the same information with a question that's arguably a little bit better and a little more personal. All right, and these last two, what do you think is going on? Because you know what, patients, sometimes you're going to be able to know what they're thinking. I had one patient, for example, tell me that if she stood up, she thought she was going to be paralyzed because there was that much pressure going on at her spine. So sometimes it's a really good way to gauge how your patient is actually feeling about their condition. Okay, and then the last question, how does that make you feel? Personal example, when I slipped on ice and broke my leg, to most people, okay, it's a broken leg and it didn't matter that much. But at the time, I was a cross-country runner in college. So that made me feel really, really bad because I lost my identity because of my injury. Okay, next. Where is it? Where are their symptoms? And more specifically, the full understanding of symptoms. So somebody might come in for shoulder pain, but they don't even realize that their elbow pain or their neck pain or their tingling that they're getting in their hand is related to their shoulder pain. So this is where we need to make sure we have a full understanding of all the symptoms going on, especially if you have somebody with multiple body regions or multiple areas. That also gives you an idea about other certain types of pathology, such as symptoms of central sensitization, chronic pain patterns. That means we're going to get the information early on how to help this patient, maybe select interventions appropriately. I have the arm sweep written down here because this is just to clarify. If I'm seeing Susie for her right shoulder, I will do an arm sweep. Okay, Susie, where specifically at your shoulder? Is it just right here, hovering over her anterior shoulder? Nothing extending into the neck, nothing extending down into the elbow, nothing in the hand, nothing at the scapular region. This is a really good way to make sure that we have no symptoms going on, because patients at times won't tell you all their symptoms right away. So please clarify that. A body chart is a good thing to use early on, especially. And some physical therapists would argue it's the only thing that you absolutely need to do in a physical therapy subjective exam, because then the patient can see what you're trying to communicate to them. Okay, and then the last thing is to summarize their findings. Okay, so this is to make sure that you listened correctly as well. This is where the patient, Susie, could tell you, you know what, actually it's not right there, or you know what, when I raise my arm overhead, yeah, it does hurt, but it has to be right here. It seems like it hurts the worst right here, and that will probably show you. This is going to be very important to make sure that the patient feels like they've been heard, and not to mention this is making sure you fully understand their symptoms. All right, words matter. This is what I mean by that. All of these words, degeneration, disbulge, torn, being told by a physician prior to that physical therapy exam, the worst knees ever, or nothing is wrong with you. I've got fibromyalgia. Doctor said I need surgery, but we were trying physical therapy first, and then bone on bone. All of these words have already set up in your patient's head that they might not get better. They sound really scary. And for especially a chronic pain type of situation, this is the absolute worst thing that could be repeated to the patient. So starting even in the subjective history, you need to be careful of using these damaging or harmful words. We want to make people better. We don't want to make people worse. And language does matter. All right. I want to hit on the 4 habits model developed by Frankel in 1999, who was a physician that basically developed guidelines for how a physician encounter should be for a patient. So these are the 4 habits he proposed. Investing in the beginning. So the criteria for this would be creating rapport. This is the reason why you greet them, you shake their hand, you greet everybody else, okay? You're trying to show them this is a safe place and we're going to help them. Eliciting patient concern. This is starting with that open-ended question. You know, what can I help you with today? Let them tell their story. Don't ask them 50 questions. No, let them tell their story, and then you can just guide the rest of the exam. And then planning a visit with the patient. This is why it's good to frame what's going to happen, because the patient doesn't know. A lot of people don't know what physical therapy is or how this first appointment will go. Next habit, elicit the patient's perspective. This is where you ask the patient for ideas. At the end of the treatment, asking them, what do you think is going on? This is important because you're making them feel heard. You're getting their opinion. And some patients will tell you, that's what I'm here to see you for. But other patients are going to actually give you quite a bit of information. Eliciting specific requests. So this is where you're asking those questions of, what are you hoping to get out of therapy? What are your goals of therapy? What are we looking to get back to? This is important. Next here, exploring the impact of the patient's life. So gauging How severe are these symptoms for the patient, and what are they unable to do? And that's going to come out in your subjective history. Next year, third habit, demonstrating empathy. Being open to the patient's emotions. So this is one of my favorite examples, because if you have someone who's more reserved, you know what, you want to kind of echo that pattern back to you. You're a little more reserved too. You might bring your voice down a little bit, but then you sometimes have the high school athlete. Maybe you even treated them before, and you're like, all right, Dave, I'm glad to see you, man. What's going on with this knee? Let's get back here. Let's figure this out together. Mirroring what the patient needs is very important. And it's hard to gauge at times, but you have to be a chameleon in physical therapy. Okay, next, making an empathetic statement. Okay, making at least one. As you're listening to a patient's story and they're telling you how they're now unable to lift up their grandson, you say something to the fact that sounds really hard. I'm sorry to hear that. You know what? That sounds really difficult right now. This must be tough for you right now. Acknowledging the emotional aspect of their current injury, on their current disability, is important. Conveying non-verbally. Okay, so being able to listen, making facial gestures, touching the patient on the leg when it's something that's especially sad or something like that, giving them a box of tissues if they start tearing up. All of these nonverbals are showing the patient that you care. And then being aware of your own reactions. So we all bring our own biases into a physical therapy exam. Trying to check those at the door is maybe the most difficult thing, because you don't know what the patient is going to tell you next. You don't know if that patient across from you reminds you of your grandma who passed away a few years ago, going through the same thing. You need to be able to try to check your own emotions at the door, your own biases, and really help the person that's right there in front of you. And then next year, invest in the end. Although maybe not as related to the subjective history, still very important, and I want to touch on it here. First, delivering diagnostic information. Okay, going over the exam. What happened? What was positive? What was negative? Something that's a good idea, in my personal opinion, is telling patients, hey, you know what? Your bowel and bladder, we can still hold it. We don't have any symptoms going down the leg. This low back pain, hey, your hips are actually moving pretty good. This low back pain thing, we just need to make this area move a little bit better or get you a little bit stronger here. And this is great news. Okay, I like framing things this way because you don't want to make people feel like a fragile set of building blocks. You want to make them feel strong and robust. Next year, education. You want to be able to fully educate them about their pathology if that is what they need. I tell a lot of my students, as little as possible and as much as needed. I learned that from Derek Cluley, a fellow in my residency program. I feel like that was one of the best pieces of advice I could ever have related to giving people information. Because the more you start talking, the more complex it's going to get. Try to make it as simple as possible. If they ask more questions, answer them. Involving the patient in the decision-making process. This is where, I don't want to call it the elevator pitch or your sale, but this is basically what it is. Most of the time in physical therapy, you're going to need somebody more than one visit. This is where you're trying to come up with a plan, meeting the patient halfway as well. If they have a very high copay, let's face it, they aren't going to want to come 3 times a week for 6 weeks. This is where you find out what you need to do in meeting the patient in the middle. You know what, Susie, a couple times a week for 10 weeks, I really think that's going to make the biggest difference for you. But guess what, Susie? In 3 to 4 weeks, if you're not considerably better, we're going to find you the person that can help you. Okay? You're going to involve them in the decision-making process, framing what is expected of them. Okay? And then the last thing, completing the visit, asking them if they have any questions about the whole therapeutic process. Next year, Larry Benz in 2013, placebo, nocebo, and expectations, leveraging positive outcomes. This is one of my favorite journal articles that has ever been published, because basically it's using those words. Using words are very important, okay? And if you tell somebody, I'm not sure this is going to work, but let's do it anyway, versus I'm going to do this intervention and let's see what's going to happen. This has worked in the past for some of my patients. You tell me who's going to have the better outcome following that specific intervention. You want to be careful that you don't set yourself up for failure. And then finally, I just want to gently touch on this, is the therapeutic alliance is important. The subjective exam, you're going to build a lot of rapport. You're going to make that patient feel welcome. And the therapeutic alliance is this thought that if your patient likes you, and you have a great relationship with your patient, they will actually feel better. So outlined, I've put a few articles there related to how this works for patients with chronic low back pain, how it works for all patients in physical therapy, how patients' perspective on patient-centered care is important, and another systematic review related to how the patient thinks about the therapist is very important. All right, I know everyone wants to be a rock star and a superhero in the clinic, but that all starts with the subjective exam. Thank you for listening.